Introduction to the IMAM program in Zimbabwe. Acute malnutrition requires life-saving medical attention. The government of Zimbabwe adopted the Integrated Management of Acute Malnutrition (IMAM) as its primary strategy for managing acute malnutrition. IMAM employs a decentralized, community-based approach where treatment strategy is matched to the nutritional and clinical needs of the child, with the majority of children receiving treatment at home using ready-to-use therapeutic feeds. IMAM brings together all the components of outpatient and inpatient care for the malnourished child. Why IMAM? Malnutrition represents a significant health burden in Zimbabwe, with thousands of children requiring nutritional rehabilitation each year. There are many reasons why it would be inappropriate to manage all of these patients in a hospital setting. Limited access. Many patients might not be able to get to a hospital. Limited coverage. Some areas do not have a hospital within walking distance. Overcrowded wards. Hospitals do not have the capacity to admit this many patients. Exposure to cross-infection. High opportunity costs to the family. A caregiver would not be able to earn their living while staying with their child in a hospital. Therapeutic milks can quickly deteriorate and go bad. Specialized milk formulas that are used in the treatment of malnutrition have to be prepared in a clean environment using appropriate hygiene practices, so they cannot be used to manage patients in the community. IMAM was designed to address these limitations. Decentralization of treatment. Through IMAM, the management of acute malnutrition is decentralized from institutions such as hospitals to lower-level health facilities and the community, making these services more accessible. Admission into wards only complicated cases. Treatment can be accessed in the community without having to stay in a hospital. The introduction of ready-to-use therapeutic foods (RUTF) for the management of malnutrition in the community setting. The components of IMAM. IMAM has 4 components. Number 1, community mobilization. This component includes increasing community awareness of the problem of undernutrition in order to improve intervention coverage through community participation. Number 2, the Supplementary Feeding Program (SFP). This component involves management of moderate acute malnutrition. Adequate implementation of the SFP ensures that malnutrition in this group of patients does not become severe and they achieve rapid recovery. It is especially important in emergency situations such as in droughts. Number 3, outpatient therapeutic care (OTP). This is for the management of uncomplicated severe acute malnutrition. And number 4, inpatient therapeutic care, which is stabilization care or SC. This is for the management of complicated severe or moderate acute malnutrition. This diagram illustrates how a health worker needs to decide which part of the IMAM program their patient needs to be enrolled in. Let's take a look at how these 4 elements of IMAM correlate to each other in this diagram. When an acutely malnourished patient presents at a health institution, the healthcare worker needs to decide whether this case presents without complications or with complications. If the case presents without complications, the healthcare worker then needs to decide whether the child presents with moderate acute malnutrition or severe acute malnutrition. If the child presents with moderate acute malnutrition, the child is enrolled into the supplementary feeding program. If the child presents with severe malnutrition, then they move into outpatient therapeutic care. If, on the other hand, an acutely malnourished child presents with complications, that child is admitted for inpatient care. Integrating IMAM into existing health services. It is important that IMAM is integrated with other existing health services. See the video on IMAM linkages. Screening for malnutrition could be conducted at various contact points for all ages using simple screening tools such as MUAC and the assessment for edema. Screening is done at the health facility and in the community. Contact points to integrate IMAM into other health services include the Growth Monitoring and Promotion Program, GMP, Antenatal Care, ANC, and Postnatal Care, PNC, Prevention of Mother-to-Child Transmission, PMTCT, Pediatric Antiretroviral Therapy, ART, Adolescent and Adult, ART, the TB Program, the Expanded Program for Immunization, EPI, the Integrated Management of Neonatal and Childhood Illnesses, IMNCI, and micronutrient supplementation. Other contact points include special consultations for vulnerable children if available, including children from the rehabilitation department, school health programs, school feeding programs, and early childhood development, ECD. Remember, the integration between other health services and IMAM is an opportunity to effectively improve outcomes of individuals with acute malnutrition.